Welcome back, everybody. Alrighty, so we last left off talking a little bit about using sensory motor training, did I say that? Sensory integration training.
Yeah.
And so, Dan, I'd love to hear a little bit more about what exactly that looks like in clinical practice.
Yeah.
So could you share your experience with that?
Yeah. I will say that if you're going to do sensory integration training, or even quantitative sensory testing, which would be the testing portion prior to the training.
Yeah.
I don't think any patient would walk into a PT clinic expecting to do what it is you're about to do. So there needs to be, as we talked about earlier, educational interventions leading up to that point.
Right.
Otherwise, it's like, why are you asking me if I'm being touched with 1 point or 2 points?
Right.
My neck hurts. Why are you?
It's like, duh.
What does that matter?
Yeah.
So you have to frame doing the testing and training in the context of how it relates to their pain experience.
So you're really you're not always referring to like quantitative sensory training. You're not doing that like first day, like often.
Oftentimes, no. I might assess it. Depends on how long that patient interview takes, which we talked about earlier is probably paramount in this patient population.
Right.
But if I've got time to do it, I'm going to do some quantitative sensory testing, maybe even some implicit or explicit motor imagery testing, which we can maybe talk about later.
Yeah.
But as it relates to the sensory integration training and quantitative sensory testing, you have to give some information as to why you're doing it.
Right.
Right. So what that looks like is, pain is a multifactorial experience. Yeah. Some of what can contribute to the development of persistent pain is the information that is coming from that body part into your central nervous system and the way that information is processed.
For sure. So
if the information coming in is not giving you an accurate depiction of what's actually going on in that body part, then you're processing information that is inaccurate, and you may get an inaccurate output, which pain is a version of an output.
Yeah.
So if we change the input, make that more accurate, the output can improve.
It's kind of like helping to kind of make it more like, okay, pain is ultimately a protective mechanism, right? But sometimes like that overprotectiveness, it's like, it's not quite matching up with the experience that you want to have.
Right.
Right. So,
another example of that could be something like hunger.
Yeah.
Right. You have, your gut has a phenomenal nervous system that communicates with the central nervous system. And when there's a particular environment, your brain gets information from afferent or ascending pathways. Your brain will process that information and you feel hungry, right? So with pain too, I'm getting information from my periphery constantly.
Yeah.
And based on the weight of that information, the strength of that information, it's going to elicit a certain output. So we rely on information in to have accurate and fine-tuned information out, both sensory and motor.
Yeah.
So if you frame it from the perspective of, we want to make sure that your central nervous system is getting accurate information from the painful body part.
Yeah.
And this is a way I can test that.
Right.
And when that information is not accurate, that's something that can contribute to persistent pain.
Right.
Right. So then you do your testing. All right. So maybe a long-winded response on how I would approach that with a patient.
No, it's great.
But then actually doing it, things like 2-point discrimination testing. So how far apart or close together can these 2 points be before you no longer feel that it's two distinct points?
Right.
And we have normative data to compare that to, and you have non-painful body regions to compare that to.
Right.
Hopefully a non-painful side to compare that to.
Hopefully.
Localization. So once you have that distance, that 2-point distance, can you tell if I'm touching point 1 or point 2? Or if they're good at that, then maybe you do 4 points, 1, 2, 3, 4.
True.
Graphesthesia. So if I trace letters or shapes, can you tell what letter or shape I'm tracing? And that's just assessing how is the information coming in Mm-hmm. Is it accurate or is it inaccurate? Right. And we want to improve the accuracy of that information. So that's how I would test. And the training looks very similar to the testing.
Sure.
Right. And you want to aim for something like 80%, 75% success. You want some error. Mm-hmm. If there's no error,
you're not learning.
There's nothing to learn.
Yeah.
Right. So you want some small degree of error. If there's too much error, people get frustrated. And are you just guessing at that point? In which case, you're also not learning.
Right.
Right. So that's what that would look like. And there are staged progressions of that.
Yeah.
So from the sensory integration and quantitative sensory testing perspective, that's what I would do. Mm-hmm. Alternatively, you could test like repeated stimulus, right? So if I take a brush and I lightly, stroke that brush on, if someone's got chronic low back pain on their low back,
right?
As I continue to apply that stimulus, do you experience pain, and does that pain rating change over time? Mm-hmm. And that could be indicative of temporal summation, perhaps, right? Yep. So that's the sensory side of things that I would assess for and then treat if there's impairment.
Gotcha.
And I try to frame it from an input-output perspective. Mm-hmm. Right? And I think many patients find that to be in the biological realm of things. It's not solely in the biological realm of things. But that's where many patients are comfortable.
Yeah.
That's where many PTs are comfortable.
Right, exactly. I mean, that's something that we're kind of taught. We're taught like these manual techniques. We're taught to observe range of motion, strength, very biological in nature.
Yeah.
And I think it can be tricky to figure out like, okay, well, a lot of this is also psychological too.
Yeah.
But where do we draw the line between us kind of delving into those psychological issues?
Yeah.
And I feel like that's even when I went to CSM this past February, that was something I've like heard from a lot of PTs when we were talking about mental health in particular.
Yeah.
Like, where is our sort of, where do we kind of come in? Like, how far should we delve into that before saying, oh, this is more of like a mental health psychologist sort of thing versus PT? What is your perspective on that? I'm curious.
Yeah. It's such a sliding scale.
Yeah.
Too.
Imagine.
It's, so I would also say that it's not one or the other, like this is my role, this is your role. Mm-hmm. This is the role of the PT, this is the role of the psychologist or psychiatrist or mental health provider.
Yeah.
We have the fortunate ability to co-treat with those professionals.
CARD, right?
Yeah.
Yeah.
Center for Anxiety and Related Disorders. Mm-hmm. And their area of expertise is in cognitive behavioral techniques, which in physical therapy we can use cognitive behavioral techniques, but we're not providing cognitive behavioral therapy. It's not in our scope of practice. So that's sort of been adapted in the PT world by Peter O'Sullivan, and it's coined cognitive functional therapy.
Right. Yeah.
Right.
CFT.
Correct. So we borrow a lot from the psychology literature, but what I think is important to remind ourselves of is that we are not treating psychological or psychiatric conditions. We're not treating those conditions.
Right.
We're treating a pain problem that may have elements rooted in psychological or psychiatric diagnoses that are coexisting.
For sure.
So in that scenario, having a multidisciplinary approach seems to be pretty advantageous.
Absolutely.
That is not to say that everyone who has chronic pain needs to be seeing a mental health provider.
No.
And that doesn't mean that anyone who has a mental or behavioral health diagnosis is going to have chronic pain.
100%.
Right? There's some association, but I think we need to focus on we're treating a pain problem. Mm-hmm. We have a skill set that can help people to manage that, but we're not treating psychological or psychiatric conditions. Yeah. We're not treating someone's depression. No. We're not treating someone's anxiety or PTSD. Those things can contribute to the maintenance of a pain state.
Absolutely. It's like that top down or like the descending inhibition that we say, like how much like our psychological state has a huge impact on that. But
absolutely.
And I think and maybe like, you know, it's interesting because you say like we're not treating it, but in some cases I feel like there is a sort of back and forth. They're connected. Right. It's not like mutually exclusive.
Correct.
Right.
There's no line in the sand that says this is where the PT intervention ends and the mental or behavioral health intervention begins.
Yeah. But I think but at the same time, like that, you know, I think knowing that we as PTs can borrow some of these techniques.
Yes.
But, you know, our focus is not on treating the mental health condition.
That's
it's
correct.
On treating the pain.
That's correct.
I think that's so important. I mean, but it's such a fine line, you know?
You cannot remove the brain from...
You really can't.
Even acute pain.
Yeah, absolutely.
Like if someone has an acute injury, there's worry. There can be rumination, anxiety associated with, you know, I just hurt my knee, but I need to do this thing in 2 weeks. I'm not going to be able to do it.
Yeah. Or when people have imaging and it's like, oh, like I got this, but there's nothing on there. They said, oh, I got an x-ray. There's no fracture. Why am I still in pain?
Right. And you'll hear patients oftentimes remark, if you're creating a space for someone to feel safe enough to really open up about how they're feeling related to their pain, then you're going to hear people say oftentimes like, oh, this is like mental therapy too when I come here.
I have heard that. That's kind of funny.
Which I love.
Yeah.
Because to me, that means you felt safe enough to allow that to happen.
Right.
Which means your alliance is strong between you and your patient.
So important.
But yeah, I draw the line at like, you actually need treatment for your depression. And we're having tools that are helpful for us to steer people in that direction. So things like the start back tool when someone's high risk, that would suggest that person can stay in physical therapy certainly, but would predict that the outcome would be enhanced if they were to get multidisciplinary care.
So referring them to those sources.
Yeah. Correct. Or having a conversation about that. We're going to start using something called the OSPRO YF.
Oh, yeah.
OSPRO yellow flags.
Yep. I've seen that.
And scoring that tool can help you to direct, like, does this person need care for mental or behavioral health?
Yeah.
And if so, what sort of domain does that best fit?
Right.
And we can steer people a little bit more specifically. So there are some things coming out now that are going to make that conversation easier because you can use responses that they've identified on the tool and just repeat those things back to them.
Yep.
And say, and some people are already coming in with a mental health provider that they see.
Yeah.
Had that experience just this morning.
Oh, really?
So, people will say, yes, anxiety, yes, depression. So something as simple as like, how are you managing those diagnoses? And do you have someone that you see to help manage those diagnoses? Many people do. I find that, again, as long as you're coming from a place of compassion, curiosity, people are more than happy to open up about it and talk about it.
That's great.
Yeah.
It's great too that you talk about like the outcome measures too are more than just numbers. Like I think.
Oh, absolutely.
No, I think it's really easy for us to be like, oh, front desk is gonna they'll like get the outcome measure, you fill it out, and like we talk a lot about cutoffs in particular. I think we're taught, oh, this cutoff means they're at high risk or medium risk or low risk.
Yeah.
But like I think you bring up a really good point of saying like they're more than just the numbers. We've got to see what those responses are telling us.
Absolutely.
And using them as conversation points, which obviously is harder. That takes more time because you have to look at it. And especially, I mean, you being at BUPTC, that's a very busy clinic. You folks are like seeing so many patients.
Yeah.
Do you find that that's often a challenge to kind of really like sink in and like analyze that data so that you can best help that patient?
Yeah. It's intentional. I don't know that it's hard, but it's purposeful. It's intentional. You have to make the choice to do that.
Right.
So one of the things that I firmly believe, and I gave myself this line in the sand.
Ooh,
that
I'm excited.
Well, Dr. Alan Jetty, he, what was the name of his talk? like Face Into the Storm or something like that. Apologies for not having that memorized. It was a phenomenal talk. But one of the things he talks about is doing the right thing for the right person at the right time.
Mm-hmm.
So, ever since I heard that, I was like, that's what I need to do. I just don't give myself any leeway to take shortcuts and things like that. So it boils down to, do I want to do the thing that's easy, convenient, path of least resistance, which is oftentimes, again, our comfort zone is that joint's stiff, I'm going to manipulate it.
Right. I've been trained to manipulate. Yeah.
Or to talk about tissues, functional anatomy.
Yep.
That's a big comfort
Healing
zone.
timelines.
That's a big comfort zone.
Yeah.
But it's, especially in people who have chronic pain, that's oftentimes not the right place to be spending your time. Mm-hmm. So there has to be a commitment to have the right conversation as opposed to the easy or convenient conversation.
Right.
So what that includes is, they checked, it's terrible and it's never going to get better. I can just pretend I didn't see that and hope that I can find an irritated tissue. Or I can take a deep breath and ask about it, and be prepared for the response. I've had experiences where actually following up on those questions has resulted in, a box of tissues in the room, a very emotional response.
Yeah.
But if that's the response you get, that's probably the thing that needed to happen.
Yeah.
Right. So I've had those experiences, and every single time I'm glad that it's happened.
Yeah.
I don't think I've ever regretted it.
Mm-hmm.
But there have been times where I've not done it and probably regretted it.
Yeah.
Or at least came to it a little bit too late. And I'm like, dang, we could have gotten there quicker.
It's hard though, and I think it also takes a lot of patience too, of like just being like, oh, I've recognized this, but like, this is not something that I could just do instantaneously too.
Yeah.
I'm like,
But it goes back to create a space and approach that in a way that is inviting to your patient to talk about something hard.
Yeah.
Right.
Creating that safe, like really a truly safe space where they feel safe.
Yeah.
It's like, I think, what was it? The other thing at CSM they talked about was how, with pain, like with chronic pain, it's more than just telling a person about the nature of their chronic pain. It's about making them feel on a very like truly like autonomic, like nervous system level, safe and comfortable.
Yeah. And what is better evidence that you're doing that than your patient feeling open and vulnerable enough to cry?
Yeah, honestly.
Right.
That
I don't try to make
No. But we don't try to make patients.
But if that's the response that you get from inviting them to open up about their pain experience, I don't think there's ever been a time where I'm like, I really wish that didn't happen.
Yeah.
And I find that that's a necessary starting point
100%
for some folks.
Yeah.
And then it's like, I feel like the therapeutic relationship is just enhanced from that point on.
So, if a patient is like struggling with this, with like chronic pain for such a long period of time, 6 months, 10 years, even 20 years maybe, like I can imagine if they've gone through so many providers who have kind of invalidated what they've gone through, it can be tricky to try and go to a PT and try to get help.
Yeah.
How do you think we can invite them in? Like, what do you say to a patient to like say, hey, like you should come, like what should they know?
Yeah. That's a good question. And
right?
People's experiences, unfortunately, even within PT, are so variable.
Yeah.
I think us as PTs, we're in such a unique position to have a huge impact with this patient population. You think about things like opioid prescriptions and the sequelae of events that can occur with opioid dependency.
Right.
We're so well positioned to help put a big dent in that, and it's a big problem.
Very.
But unfortunately, there's so much variability in the PT profession, right? So I can speak to what someone could expect coming in here,
right?
And why someone should come to a place sort of like this. Not that we are, the best of the best, and well, maybe who knows?
Who knows?
But
I guess like maybe who should they be looking for? Like especially in a PT, like
So first, I would say someone who's open, curious, a good listener.
Yeah,
gives you the space to tell your story.
Yep.
So sort of providing that environment first and foremost. So you should, as a patient, when you first meet your PT, you should feel comfortable talking to that person and feel like you have an opportunity to tell your story.
Yeah.
Number one.
Yep.
Number two, you should look for someone who's, not just going to deal in the biology domain.
Right.
Right. You don't want some guru who says, looks like your pelvis is out, and if I'm going to get rid of your 10 years of back pain by putting it back in place.
Crack, you're fixed.
That's head for the hills territory.
Yeah.
Right. You can expect to have your thoughts, beliefs, feelings about your pain challenged, but in a very professional way.
Yeah.
And from the PT side of things, one thing to just add that I didn't get to earlier is anytime you try to challenge a belief, there likely is going to be some resistance. And part of the reason for that is any information that you have or evidence that you have that is counter to someone's belief or their internal construct of the painful body part is not going to be weighed as heavily as information that supports that internal construct. Right. So if I'm trying to change someone's belief, it's not going to be easy.
No.
Right. And that's not true just in chronic pain or PT. Like, think about politics.
True.
We're not allowed to talk about.
No.
But if I see a piece of news that aligns with my viewpoints, I'm more likely to believe it to be true,
right,
than an alternative viewpoint. Right. So there's work to be done there. So as a patient, you should be seeing someone who is willing to put in that work.
Yep.
Right. And I've had experiences where that has been the thing that gets us on the right path.
Yeah.
Is really changing the belief.
Being willing to like engage in that challenge.
Correct.
And, like, again, professionally speaking, but also just like recognizing that resistance. Like, there's going to be that resistance.
Yep. And that's okay. It doesn't mean that they don't like you or you don't like them. It's healthy sort of discourse.
Yeah.
Right? That probably needs to happen. So you should, as a patient, expect some of that. There's interventions that we now have that are very promising, that are very low risk.
Yeah.
Things like what we talked about with sensory integration training.
Right.
So trying to get the nervous system sort of back, giving you accurate information about that body part.
Gradually increasing that accuracy.
Yep. Motor imagery.
Yeah.
So if there's changes.
Wish we had more time to talk about this.
Changes in the motor cortex of the brain.
Yeah.
Then we have interventions that can help with that. So various types of motor imagery. You can eventually expect to be challenged to use the painful body part through graded exposure. So ultimately, it's expects education, but in a curious, compassionate way, where the intent is solely to help to reduce your pain.
Yep.
Training the sensory system, training the motor system, and exercise and manual therapy.
Yeah.
Right. Those things, the risk of doing those things is largely your time.
Yep.
Right. The risk of taking an opioid is many.
Lots.
And the magnitude of those risks are huge. Right. So we are learning so much. Even in the last decade, we've learned so much. So we now have these tools that we didn't previously have that really do help people.
Yeah.
I've had 3-4 experiences, at least that come to mind, where I truly believe that if not for that skill set and these interventions that have come about in the last decade, I truly believe they would not have gotten better if we didn't have these things.
Well, I think we are, so just to clarify, we are kind of running low on time.
Sure.
I'd love, honestly, just to end this off on like one particular story of those like 3 or 4 that come to mind. Like what's one that, well, like one success story you've had that's really stuck with you?
Yeah. Okay. I got to choose here.
I know. That's a hard question, I know.
Okay. So I'll give you the most recent one
in
memory because it'll probably be the most accurate. So an individual, and I'm going to be very vague in certain respects to preserve
absolutely
identity. So an individual who had an acute tissue-based injury that was very diagnosable on imaging. There was a mechanism of injury, so the mechanism of onset was very clear.
Yeah.
Fast forward 2 years, the pain is still there. Okay. So initially, this person came in already sort of understanding that there wasn't a whole lot of cause and effect with how they experienced their pain at this moment. So I had sort of the entryway into, I agree with you that what you're telling me causes your pain to increase is not the same things that stress the tissue that you injured 2 years ago.
Right.
They're incongruent. So I already had that in. That made it
you've started working with
easier.
now. Yeah.
Yep. And this person comes from a scientific background, so also having some of these discussions is helpful to have that background.
Right.
So this person was able to actually use the painful body part like pretty heavily and not have pain. The things that triggered it would be things like high levels of emotional stress.
Yeah.
Lack of sleep.
Yeah.
Looking at triggering images or hearing triggering words that were consistent with this person's worst fears about the body part, right? So then, a lot of talking during the exam, did quantitative sensory testing. 2-point discrimination was impaired. So the discussion there is the information coming in could improve in its accuracy. So that way, the way that body part is represented in your brain can change.
Yeah.
Right. So we did a bit of that, and then making some progress. And then about midway through, this person had a scheduled visit with an orthopedist, and the orthopedist told this person that the pain they're experiencing is likely to always be there. So that next visit was when we were in the room with a box of tissues. Wow. So that's where I say you have this person was told something that although it comes out that I don't trust that doctor, they don't know what they're talking about. But the thing they told you is causing this huge response, this big flare up. Like, you don't trust this person, you don't believe what they're telling you, but it made the body part hurt more just from hearing that.
Yeah.
So do you really believe that this can get better? Is what I asked. And then the person said, no, I don't.
Wow.
Right. So that was the moment where we got to the true belief that I don't think this is going to get better.
And then challenging that.
Correct.
Where are they now?
Discharged. Yep. A very great deal better on the global rating of change.
Oh my gosh.
So we would not have gotten there if it were not for being able to get to the very bottom of that internal construct.
Yeah.
Right. And clearly any information I had contrary to that internal construct was not weighed as heavily as a doctor that they didn't even trust or think knew what he was talking about. That information was weighed much more heavily than, I can run and the body part doesn't hurt.
Yeah.
Like that dip wasn't weighed as heavily. So we had to get to the very, 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 very bottom before any progress was made.
Wow. Such a great story, though, like of like leaning into that challenge.
Yeah.
So thank you for sharing that.
Of course.
Truly. Yeah. All righty. Well, we are unfortunately out of time. As much as I
want
to hear more from
you.
No, I love it. Thank you so much for sharing. But Dan, it's been a pleasure having you on the, I want to say show, but
the podcast
show, you know, it's going to be a multitude of things, but
cameraman Jared.
There you go. Thank you to Jared.
You always got to shout out the cameraman.
Always got to do that. But thank you to our listeners and our viewers for joining us at this episode. Look forward to some more, to hear more from other clinicians, and we will see you in the next episode.